We welcome on stage, sir.
So I hope we all understand that we are a little late in the evening to be too formal about proceedings. So we'll compromise on, in that sense. So can I have the next slide, please? So what we intend to do in this session is call on our esteemed speakers, guests, and panelists who are working on those domains in which AI has already made significant inroads. So first is Dr. Somesh Gupta. The yeah. So I think the fact that he has almost 400 publications itself speaks of his eminence and experience. And when we were trying to curate this CME, we were trying to look out for clinicians who are working with AI or in the fields where AI is sort of ingrained. And whomsoever I asked, Sir's name cropped up, invariably so. So Sir is there. He'll talk about how his practice in dermatology is getting influenced by AI. Can I have the next slide, please? Dr. Deepika unfortunately could not come. We have a voiceover video PPT of hers. If time permit, we'll play that as well. Next slide, please. And then we have Dr. Subhash Yadav. Please welcome Dr. Subhash. He's somebody who's, again, prolific writer and is a pathologist, and he does a lot of AI-enabled diagnostics, as I've been made to understand. Next, please. And of course, our own Group Captain Rahim. So I think while we call on speakers, somebody can help me with the stage management side by side by putting in more chairs. Can we have just one more chair, please? Because I think Colonel Subhash Shaw is also like to join us. So Group Captain Rahim also is involved in AI NIDUS or a tech NIDUS, which we have in AFMC and ably supported by Colonel Sanyal, whom we have already heard, and also by Arnab Ghosh. Dr. Arnab Ghosh, unfortunately, is not here today. He'll be there with us for tomorrow's session. So next, please. Yeah. And Colonel Subhash Shaw, I would say he's a doctor, gentleman, saint, intellectual, prolific reader, student, all rolled into one. And I'm not going to the nitty-gritties and semantics of all what is there on the screen. That's for all of us to say. So what I'll request is, of all the speakers, I'll call them out one by one. I'm going to moderate this session. I'll sit on that side and request all of them to share their insight as to how AI has, they're all very senior in their own domains, fairly experienced. So how AI has made inroads into their field, into their own domain, how they had to learn certain skills if they had to at all, right, in order to adapt to these technologies, and do they have something to inform us and tell us as medical educationists as to what we should be teaching our students so that tomorrow they're able to adapt to AI or in particular, or technology in general, more seamlessly and more readily. So I'll vacate the podium, sit there, and then we can have this discussion. Of course, we'll try to take, of course, we need to take input from the audience, which is by no means less eminent than the speakers. With that, I'll request Dr. Somesh to start, informing us as to what he thinks about that.
Thank you, Colonel Praful. It has been such a day full of learning, and I'm enjoying every moment. And thank you for inviting me to be here. And on quite a few things.
Mic check, please.
Yeah, I learned quite a few things since the morning, and it was enlightening in many ways. So as all of you know that the the earliest AI came with deep learning models coming in way back in 2017, 18, becoming popular and accessible in India. So at the time, we started working on image recognition based model for dermatology. So you know that, in dermatology, pathology, radiology, or even some part of ophthalmology is heavily based on pattern recognition abilities. And humans, if you read the evolution books on evolution, you know that humans are not good in identifying patterns as compared to our other primates. So, for example, a video, a very viral video in 1990s on BBC television where a chimpanzee repeatedly beating human counterparts in identifying the numbers in a quick time, so on a screen. So that pattern recognition ability of humans has always been, suboptimal. So therefore, the image recognition technologies we thought would be going to a good boost in clinical practice. So we started working on that. And most of the time, most of the models which were available at that time were on binary classification model. That is, either a skin lesion has a cancer or it doesn't have a cancer. But it doesn't serve our purpose because we don't just see cancers. We see many patients coming with many different skin lesions which have different patterns. So we started working on multi-class classification, and we could produce a good sensitivity of around 80% for 50 common skin diseases. So although the total number of skin diseases runs into several hundred, but if you look at the patients coming to us, these 50 common diseases would cover more than 80% of the patients. And when it comes to primary care physicians, their ability to diagnose skin conditions. So more than 40% of the patients coming to primary care physicians are related to skin. And their ability to diagnose skin diseases as compared to dermatologists is just 40%. So, we were trying to bridge the gap because most of the dermatologists, they are centered in the big cities, and a large part of the country is devoid of dermatological expertise, and primary care physicians, they were not able to handle the situation. And the Google France data suggests that the most common health related problems which are searched on the Google are skin related. So people are quite concerned and they don't have access to skin health. So then when we worked on 50 skin diseases, we could reach to 80% accuracy, but we hit the ceiling. We couldn't go beyond it. So that's why we thought that it has to be a multi-model model. Means it cannot be, we cannot depend on just one technology to achieve the optimum solution for any kind of pattern recognition technologies, be it radiology, be it dermatology, or be it histopathology, or any other specialty which heavily depends on pattern recognition. So now we are working on multimodal model, and recently this Ministry of Education, we won the contest of Ministry of Education. They advertised one contest for AI in Healthcare Center of Excellence, and some 30 institutions participated in it. Eventually, it was given to, based on they gave us 6 months to perform, and then we got it on the basis of competition in collaboration with IIT Delhi. So here now we are going to implement, like, it is not just image but also the patient metadata, and if we can combine the two to produce a better outcome of a diagnostic assistant which can be incorporated in the clinical practice. So this is about our own work and our own future aspirations, but a lot has to be done. And another problem which we face is that creating a technology is one thing, but integrating it into the healthcare system is entirely another. Even if you produce a very good solution, unless it is not accepted by the medical fraternity or those who are end users, then it is not going to succeed. So this is what happened. We tested in 5,000 patients our application, and what we found is that the best performance was in the urban private practice, and then rural areas, and then in tertiary care center, because tertiary care center gets difficult cases, so atypical morphology. But what we found is that these tools, they worked very well in the hands of dermatologists who already know. But when we tried to assess in the primary care physicians, it didn't work so well. So another problem and big challenge is interoperability. So, and a recent study, a very interesting study published last month only, that they gave, this was a randomized trial in which the chat GPT was tested against chat GPT plus a human physician and human physician alone. So chat GPT performed better than human physician and human physicians plus chat GPT. So even if you have a tool and you don't know how to use that tool, it's not going to work. So that's in brief. Yeah.
Thanks a lot for your input, sir. So before we ask the audience about a possible question from their side, I would want to ask you one thing, sir. That one challenge which you probably faced was in, if I may use the term, selling of the technology to the people at large. I'm just using for the sake of convenience. So it was because, let's say, like you said, that primary care physicians were not able to use this technology. Was it because they were not aware of the terminology imperatives, or they were not aware of the technology part of it, sir? So what could have optimized their uptake?
So even we with the help of NGOs, we tried to implement it in certain primary, what you call mohalla clinics in Delhi areas. But I think they were not so, they are not so familiar with the technology, number one. And triaging is a problem because they are already overburdened. And if you want to add another step in a management of patient while a long queue of patient is already waiting for them, then it's not going to work. And there are so many other challenges. It has to be very simple. It has to be smartphone of, deliverable, and there are many variables. So creating a technology is one, but implementing is altogether a different kind of challenge.
So I guess we are looking at a loop wherein, since we are busy, we are not finding time to adopt the technologies, and that's what it's keeping us busy all the time. So that's an interesting aspect. Can I have one quick question from the audience? Of course, we'll have more questions at the end. Yes, sir.
I must ask him something. So, so what I wanted to know was, when we see patients, we see the patient in 3 dimensions, whereas a photograph is in 2 dimensions. And it's at least happened with me several times that when I've seen the patient directly, I've had a different impression than when I've seen the photographs before, because the photographs were in 2 dimensions, of course, in slightly more difficult cases. I'm not talking about the absolutely garden cases. So the 3rd dimension gives me an additional perspective. Now, what I want to know is, now your images are all 2 dimensions, and the resolution of the images, of course, would vary depending on how they have been taken. So would the lack of a 3rd dimension be an impediment to the incorporation of AI in dermatologic diagnosis?
Thank you, Manas. That's a very important question. At the same time, while ideal would be a 3-dimensional image, and AI trained on that 3-dimension image data set. However, this is not going to happen in near future. But what I found is that in spite of having just 2-dimension image accessible to the AI solution, it comfortably beats in specific tasks to dermatologists. And the best example is of skin cancers. And all over the world now, the AI-enabled diagnosis is superior to dermatologist diagnosis as far as detection of skin cancer is concerned. So in that specific task, even with the 3-dimensional access to 3-dimensional examination, the 2-dimensional image in AI conveniently beats it. I give you another example. What AI can read in an image is, and analyze is enormously different from what we look at it. Atopic dermatitis. So some of the patients with atopic dermatitis have atopic dermatitis because of the filaggrin mutation in a protein gene, protein which is expressed in the skin. So AI, when it was tested, the AI was fed with the skin images. It could accurately diagnose filaggrin mutation in more than 70% of the patients by just looking at the images. And what we are working in collaboration with AFMC is we are trying to find out whether by just looking at the facial images, the AI can detect metabolic syndrome in patients with chronic plaque psoriasis. Because this has been replicated, not exactly this, but a Chinese study suggests that by just training the AI model with the facial images, it can detect the heart condition in a patient. And an Australian study suggests that by just looking at the chest CT scan, it could predict 90% correctly the mortality in the next 5 years of a person. So by just looking at the CT scan of a person, which is also two-dimensional, the AI can predict accurately whether this person would survive for next 5 years or not. No other data.
So, just one little supplement. What about adding dermoscopy? We know that in malignancy, the addition of dermoscopy is actually the thing which has made the difference, rather than the clinical images. So, so would you think that the addition of dermoscopy, a clinical and a dermoscopy, would make things better for AI, especially when we have this issue with primary care physicians?
Yeah, I completely agree with you. As I told you that by having just one kind of information, we had already hit the ceiling, and we couldn't improve the accuracy of the AI model further in spite of adopting the newer technologies. So if we have like multimodal inputs, like patients' metadata and other things like dermoscopy images or histopathology images of the same patient available to the AI tool, the accuracy is going to be super high.
Thank you, sir. So what I understand out of this is that one thing, it's easy to create technology probably these days, but difficult to apply. One of the reasons would be because it need to be sold in that sense. By explaining it well, probably it will take some time. And to explain it well, ab initio, we need to understand it well as well. And also, it will be difficult to apply or implement technology in one silo. We may use it in a silo, but it has to apply probably in a more 360 manner. I think we are on the same page on this. So with that, let's move on to Dr. Subhash and let's see what he has to say about integration of AI or AI in his field.
So I have a small presentation if I can run that. So it's about